All right. Good morning, good afternoon, or good evening to everyone. Welcome to our second HDC webinar on the Harmonized Health Facility Assessment. This first HHFA webinar was held on October 10th, and it explained what the HHFA is, how it can support health system planning and monitoring, and then it introduced the key tools for each step of the survey. So today, in the second webinar, we'll discuss country and regional experiences implementing an HHFA and using the results. So we'll start with some opening remarks from Steve McFeely, the director in the Data Analytics Department of WHO. Then we'll hear from Ghana, from Dr. Anthony Odofu-Osufu, the Deputy Director General in Ghana Health Services. Then we'll hear from Maldives, from Mrs. Taslima Usman. She's Deputy Director General and Quality Assurance Commissioner for the Ministry of Health. And then we'll hear from Somalia, from Mr. Hassan Ahmed Mohammed, Head of HIS, Research and Statistics at the Ministry of Health and Human Services of the Federal Government of Somalia, and also from our country colleague, the Data Manager in WHO Somalia, Mr. Komlacho Mengistu. Last but not least, we have with us today our regional colleagues, Dr. Amani Siam, Regional Advisor, Health Information Systems from WHO Regional Office for Southeast Asia, and Dr. Drochi Benson, Team Lead, Health Information Systems at the WHO Regional Office for Africa. After the presentations, we'll have a short time for some questions and answers. So there is a Q&A box in the Zoom window. Please feel free to pop in your questions in there, and we'll take them by the order. And then we'll hear from Craig Burgess. He's Unit Head for Coordination, Governance, and Partnerships at WHO, but also works at the HDC Secretariat, and we'll hear from him some closing remarks. But before we start, please note this presentation is being recorded, and this recording will be made available via the Health Data Collaborative YouTube channel. And then you can check all past webinar recordings since January 2023 in there. So if you missed, for example, the first HHFA webinar on October 10th, you can watch back the recording via our YouTube channel. I will now give the floor to Steve, who has kindly agreed to introduce today's theme. So Steve, over to you. Thank you.
Thanks a million. So hello, everybody, and thanks everybody for joining. So good afternoon, good evening, or possibly good morning. And thanks for joining today's webinar, the second in this two-part webinar series. In the first webinar, we introduced the HHFA, or the Harmonized Health Facility Assessment, and the concepts and package of tools that support countries to implement high-quality HHFAs. Today we'll be presenting the HHFA, WHO's Comprehensive Health Facility Survey, in a bit more detail, but specifically we'll be hearing from countries and about their experiences. As a quick reminder, the Harmonized Health Facility Assessment assesses the availability of health facility services and capacities of facilities to deliver quality healthcare. In doing so, it provides evidence of the status of the country's health service delivery system, and in turn, this helps to identify gaps in systems and inequities in the systems. Since the first HHFA, which was first piloted back in 2018, at least 13 countries have implemented the survey, with Guinea-Bissau and Zimbabwe currently undertaking HHFAs. But really interestingly, today in this webinar, we'll hear from three countries, Ghana, Somalia, and the Maldives, about their experiences in running a HHFA and how those data have then been used. Each country represents a different WHO region and a different context. Ghana represents obviously West Africa, Somalia represents the Horn of Africa, and the Maldives represents small islands. So all very, very different contexts, both regionally, politically, economically. And each of these contexts have their own priorities and challenges. Yet all three countries have successfully implemented a Harmonized Health Facility Assessment and is using those results to inform their planning processes. So thanks again for joining us today. At the end, we'll welcome any comments and questions during the Q&A. And with that, I'll hand back to the compere. Thank you.
Thank you, Steve. So now over to our colleague from Ghana for the first presentation.
Okay. Thank you very much. And good afternoon, good morning, good evening to everyone. So I'm presenting on the Harmonized Health Facility Assessment that was done in Ghana in 2022. So there's the outline of my presentation. The background of it all was that we conducted it in the last quarter of 2022. And we looked at the inadequate facility data that was there. From the score assessment, Ghana, there was a 34% gap when it comes to facility assessment. So this was an issue of concern for us. And then also we had no comprehensive national assessment of service availability, readiness, and quality to date. That we've never done a SARA before. We've never done a SAM. So there was paucity of data on that score. And then also the need to determine the status of health facilities and identify gaps. We wanted to do some new changes in the service delivery, and we needed to have an understanding of that. And then also the need for comprehensive and comparable data to inform the innovation that we were looking at, and then also informing planning and guiding resource. So the process that we did, we covered all the 16 regions and 261 districts of Ghana. And we did primary and secondary health facilities were surveyed irrespective of ownership. So we did both public and private facilities, and field-based facilities were included. And then also we looked at agreed indicator to assess the availability, readiness, and management and finance. So we did these three models. Because the quality model was a bit different in the way it was supposed to be done, we left that one out. We'll be doing that one in 2024. So we did a blend of purposive and random sampling procedure. For the regional hospitals, we did a census of all the regional hospitals. And then we did a census of all the district hospitals and polyclinic. And then we did representative samples of health centers, network of practice hubs, maternity homes, clinics, and CHIPS compound. About 1,000 facilities were targeted for the assessment. Yes, and we formed regional teams of 10 led by the deputy directors of clinical care. They constitute the regional team as regional supervisors, team leads, and data collectors. And we allocated the facilities to the regional teams. So in summary, it was how it looked like. We had 1,421 facilities were interviewed, and these are the distribution of the facilities in terms of the categories of facilities that we had. Health centers being 28%, and then clinics 17%, and then the hospitals were 21%. So that was it. So the activities that the various activities that we did, the concept development and formal requests was done in August, September 2022. Protocol development and ethical clearance procedures we went through in August. November, stakeholder engagement orientation were done, adaptation of the questionnaire and tools, and then training of data managers on CISPO tools, adaptation and server configuration, and data collector training of trainers. Then we did training of data collectors and supervisors, including the field testing. Then we started the data collection in the last quarter, that is 5th December to 15th January. And then we did post-data collection assessment, data cleaning and validation in the first quarter, also January, February. And then data analysis continued, the engagement with program. Then after that, we started engaging the programs to review the preliminary results and get their feedback. And then we went around the region to get validation of the results. And then we finally put together dissemination, and did dissemination in October. And now we are doing the regional specific interpretation because we want to write regional specific reports. So in terms of the way we organize it, the governance system that we put in place, the Minister of Health mandated the survey upon engagement. with WHO and others. So it came out from the World Health Assembly meetings, and then the Minister of Health mandated a survey. Director General of the Ghana Health Service provided oversight and resource mobilization. And then myself, the Deputy Director General, I was the technical coordinator and also responsible for looking for resources also. And then the Research Development Division, which is a division of the Ghana Health Service, and the Policy Planning, Monitoring, and Evaluation Division, they combined and they were responsible for the day-to-day activities. So they formed the technical team itself. And then the Institutional Care Division provided technical guidance to some, because most of the things are from the facility. And then the data management team for data synchronization and processes. And then we put a national monitoring team in place, which went around the regions to validate the data. And then we had a technical committee to guide design and implementation with representation from Ministry of Health, Ghana Health Service, and WHO. And then a steering committee, representation from Ministry of Health, Ghana Health Service, Christian Health Association, WHO, and other partners. And the WHO provided technical and financial support. So that was the governance structure. So in terms of the data analysis, we did the data extraction and cleaning from CISPRO. Then data cleaning and consistency checks were done. Final data set for analysis were generated. And then this was configured into the data inventory and analysis platform. And then we sort of look at the data, the indicators that were churned out. And then we reviewed it and modified it to meet the specific needs of Ghana based on the sort of feedback that we had with the people that we first engaged with. So then we then went ahead, and then with support from WHO and other key officers, we had a series of workshops to develop the 3 major documents. So now we have 3 major documents that the snapshots that we did for the dissemination. We did a couple of snapshots by these headings: the reproductive health, malaria, non-communicable surgery, emergency management, and governance. And that's what we use for the dissemination. And then we've done the final Harmonized Health Facility Assessment National Report, which is supposed to be signed off by this week. It is finalized now, all the editorial and everything have been done. And then we are now we did the Harmonized Health Facility Ghana experience. We document the processes that led to the implementation of the Ghana HHFA. That one was shared, it is on the Ghana Health Service website, and it was also shared by the WHO. And then currently developing Harmonized Health Facility Assessment specific regional reports. So we are doing 6 regional reports as part of the process of documenting what we've done. And then we are engaging with the programs on the results interpretation and interventions, the various programs, malaria, HIV, TB. They are looking at the report. In fact, HIV use it for the Global Fund grants. I mean, the baseline, that's what the HIV program used for that as a baseline for their grant application. And then also we've disseminated it at the Ghana Health Service senior managers meeting, where regions have been asked to own the data and use it to engage and find, this to address the gaps that are there. And then we are introducing and testing and piloting the mini Harmonized Health Facility, which Health Facility Profile that have been developing the DHIS2. Ghana have a very robust DHIS2 platform. So we think we can leverage that to do ongoing monitoring of the health facility readiness and for availability and readiness, instead of so that we can track the changes and the intervention that we do over the period. So we are piloting that tool in one of the regions. And then dissemination at the National Health Summit to all health partners, we've done that one. And then the regional engagement that I said we are doing. So we are looking at integrating this data, triangulating it with the population and health census and the Ghana Demographic and Health Survey to look at access and inequality analysis. So we want to use these 3 data points to triangulate and then analyze it to look at inequalities in access to healthcare. So this is something that we are engaging WHO and USAID on to support and do that. And then we are doing the 6 regional specific detailed reports on emergency preparedness and response across health facilities, so that by then we are using the data, the HHF data, to do that. And then we are doing some current interventions at the network of practice, where we are trying to improve the primary healthcare level using the hub and spoke approach, with the hub being the improved health centers and the spoke being the chips. So we are trying to, so this is providing a baseline for us for that intervention, and then performance for results also. And then the midterm review will be next year, and the HFF will provide some inputs into that for the ministry. One of the lessons that, some of the lessons that we've learned is that the timing of the assessment is very important. That is very important. We did it from December to January as we should. And it was the Christmas, so it really affected the work because of the festive occasion. So we advise countries that are doing this to really look at this, that it doesn't coincide with some holidays and all that, and also the weekends also. We found challenges with the timing, and it has budget implications also. And then the high commitment of all stakeholders ensured ownership and leadership for the successful implementation of this survey. It's very important that the engagement are done early to gain ownership at all levels. And that's something that I think we did very well. And then adequate funding and its timely release to conduct a comprehensive survey is very critical, because the timelines are tight. So that if you don't have the adequate funding, and then administratively to the releases are a bit of a challenge, you may run into challenges. So that's something that we advise, that anyone trying to do that should have secured all the funding and make sure that all the administrative bottlenecks and the lead times and all that, the lag time between the administrative request and release are taken into consideration. And then you need to have a research department with expertise in conducting large-scale health surveys to be in charge of the real groundwork. So either if the health sector doesn't have that experience, then maybe you need to let it out to a research or agency or academia or something. The people who are implementing it need to have an idea, expertise in conducting large-scale health surveys. And in Ghana, we are fortunate we have in-house research division that is conversant with conducting large-scale health surveys. And then also time constraints. You can do some of the things concurrently. And I think that's what we found useful, that it is not sequential. Some of the things can be done concurrently. You can need to see which of the activities you can do pari passu, so that you don't really, because there's sometimes the timelines can be tight. And then the composition of the questionnaire and tools adaptation team should include persons with clinical and primary healthcare background. So you need to take country experts who know the country situation for the adaptation. It's very critical that the country technical, especially the clinicians, the pharmacists, the nurses, there should be key country people who understand facility care and facility management to be involved in the adaptation. And then the multiple level of data reviews are useful in ensuring that the completion of all sessions by the data collectors, so that you need to have supervision really strong on the ground. Thank you very much. Over.
Thank you very much, Dr. Anthony. Now over to Mrs. Taslima Osman. Dr. Taslima.
Thank you so much. Let me just... Yeah. We're from the Maldives, and we conducted the Harmonized Health Facility Assessment in 2022 between May to August. We are actually an archipelago of 186 inhabited islands. We have small island scattered nation we are. So we have 186 islands where people are living, although the total number of islands are 1,196 with about 150 resorts. And for HHFA, we did a census of all public health facilities. We have 188 public health facilities. We did not use any, we did not do HHFA in private health facility or in a private hospital. We only did for public health facilities. We also did modules 1, 2, and 4. We did not do the quality module because it was not it was different form, just like Ghana was said. So we are also planning to do the quality module hopefully in 2024. We had about 31 data collectors, 6 supervisors, and almost it took 90 days to complete the data collection. As mentioned, we started in May. It was the HHFO was introduced initially to us by WHO country office. We had a meeting with headquarters where Wendy introduced us to the HHFA platform, and that's when we decided that we will do the HHFA. In the planning process, once we had the discussion with WHO, since we have very few healthcare people in our department, even in our research development, we thought the best option would be to hire external consultants. Especially we planned to do the whole census, so we hired external consultant firm and introduced them to HHFA, and we did an orientation through WHO headquarters. WHO headquarters also introduced us to the EFRO team. I would like to thank the EFRO team because they were very supportive throughout the data collection, analysis, and everything. We actually had further consultations with regard to indicator selection. We did consultation with public health program managers as well. We consulted the Ministry of Health because some of the questions that were there, it needs to be adapted, and things like the several communicable diseases which were eliminated from the Maldives. Therefore, some of the questions were not, it may not have been very relevant to the Maldives. So a total of 46 country-specific new questions were added depending on our country status. And also we rephrased 23 questions in order to adapt it to the Maldivian context. We also changed some definitions, like we had to do some adaptations, so because there were some discrepancies of how the terminology was used in the Maldives and how it was used in the manual. For example, the community health worker in the Maldives is actually a professional healthcare worker, which require, so similarly how inpatient services were defined or in the Maldives is different than what it was in the manual. So we did some adaptation of that. In questionnaire adaptations were done. Like mentioned earlier, we actually recruited 31 data collectors or enumerators and 6 supervisors. And we also used a team approach where we had the team supervisor and the enumerators, team leader, team supervisor, and the enumerators. And also we used a cluster approach. Like mentioned, we are atolls. So, I mean, each group was given atolls to complete the data collection. And for setting and deployment of application, before the CS Pro application was deployed, we actually configured the application for Maldivian context by referring to Data Manager's Guide. We have also followed all the steps that were mentioned in the guide throughout the process. We can say that it was starting from the question adaptation to hosting the HHA application on the web server. And also we started the process by changing, initially we started by changing the sample reference file that was given in the application. The IT team of the Ministry of Health did the configuration setup of the CS web server and used an Amazon Light Sales service with recommended computational power and specification from the FRO team who were guiding us. During the implementation phase, we had communication and engagement with all health facilities. Basically, we had people identified as who would be the most appropriate person to answer the questions that we were having, and also clarification of definition and use of different definitions were done. We had training of trainers initially. The supervisors, the leaders were trained as TOTs, and each supervisor and each leader, they trained their team of data enumerators. Application compatibility, we had a bit of difficulty because what we found was that initially the application was only compatible with Android devices. So we had a bit of difficulty in that. Because we had to use Android devices. However, our CS Pro team did some background work, and I think we were able to later use it even in the using iPhone as well. In order to track the progress towards the survey completion, we had a track progress sheet was made with regard to the data manager's guide. We also created the track progress sheet. First, it was required, we downloaded the HHFA data from the CS web server. Google Sheet tracking table was also prepared and maintained by the data managers to facilitate and give updates of the survey progress to all the reporting parties. In order to update the progress sheet, data managers downloaded the data from the data managers manual whenever team leaders were informed to synchronization of new facilities to the data. Reviewing and editing, the CSS Pro edit files were written to remove duplicate assignments and to bring edit changes to HHFA data files based on the supervisor validation of data. The data analysis was conducted on the HHA data analysis platform. The HHFA data analysis platform produced both descriptive analysis. It was based on the distribution of indicator frequency and also on comparison using selected stratified variables. The platform actually produced a standard set of indicator tables and graphs and a standard report outline. The analysis was conducted by the local experts following a 3-day training session on the HHFA data analysis platform. We had a WHO consultant training us on the HHFA data analysis platform. What was important in the analysis was that we ensured that the data, each facility data, were utilized independently rather than comparing each facility, or we actually discourage to compare one atoll to the other atoll, rather to use it as a standalone data set for that particular institute. We also had a validation workshop, which was held with all stakeholders, including the WHO representatives. Why we did it was that we wanted to make sure that the data were the quality of the data, and also we had discussion on the data during the workshop, which lasted 1 day. The group actually reviewed all the data that was provided. They commented on it. To ensure the accuracy of the data, the comments that were received from the team were double verified before making any adjustments. We would say the workshop was really very successful, actually, because it helped to validate the findings and ensure that the data was accurate and reliable. Overall, the result validation workshop provided us an opportunity for various health agencies which came together to review the findings, which also helped to improve the quality of data. The collaboration and validation process actually helped to improve the decision-making process as well. And we hope that it will ultimately improve the health outcomes too. For the production of the HHA report, we had discussions regard to what level and what to be included in the report. We decided to use all the data rather than high-level reporting, in terms that we used all the data at facility level. So we have atoll level data, and since our health system is graded into different levels, like hospitals we have 3 levels, health centers we have 4 levels. So we actually also did similar kind of reporting on, we also produce reporting based on that, based on each atoll. Like, for example, in the first slide, we said that one of the atolls may have 13 islands, one of the atolls may have 9 islands. So it's aggregated to atoll, and we also produce the data at facility level. We also produce the data at in hospital levels, like hospital level 3, hospital level 2. For example, in this, the percentage of facilities that ever offered oxygen in outpatient department, the total in Halif atoll is 93%, that they will have 13 facilities total. But we have that's a level 2 health facility, level 2 hospital. But when it comes to level 2, we see that among all the level 2, the total number is 89. So we also wanted the data to be produced in that way. I think even this, we also aggregated the data to know where our gaps were. For example, even in this, like antenatal care services, it is, we noted that although we have the diagnostic equipments, we may have the other equipments and medications, we found that the staff and the required guidelines were not available. So this is again a very important analysis for further decision making. The use of HHFA findings, actually, one use was that it actually contributed to evidence-based decision making. We also identified the gaps in health service delivery, and it assisted in focused continuity of care. During the discussion, it was noted that because it was we involved all the stakeholders, all those who are responsible, even in ensuring the availability of medication. There were discussions to say that how do you say that it is not available, because when we have this particular system where we have the required consumables being sent every 3rd month, and we see that it is available at this point of time. And what we said is that when this was done, it was not available. When the assessment were done, the particular consumable or the particular service is not available, means that we have an issue with continuity of care. So it was taken very positively in that sense. So it actually assisted in focusing our services to have continuity of care. The HHFA findings is also used to target service improvement, like we have the levels and how are we going to harmonize service availability with each level. It also assisted in the ongoing updating of essential health service package, which we are updating our essential health service package, and the HHFA data assisted in that. It also contributed to national health statistics reporting. For example, this is one thing that where HHFA actually found some national baseline data which we never had before. And we also believe that it will also assist us in tracking the progress we have. And also this gives an opportunity to do more study, research, or surveys with regard to specific services to do detailed studies. Lessons. Sorry. We have had, I would say, a lot of lessons learned when it comes to HHFA. We had with regard to preparation in the adaptation of HHFA to country context. It was a lesson learned that which I mentioned before, the definitions, what was in HHFA and what we were actually in our context, what the definition were. We also had lessons learned when it came to configuration of HHFA Pro application, the parameter setting, batch edit for activation testing, and also in the analysis, interpretation, writing, we had the issue with the understanding of the HHFA analysis platform and also the progress tracking. We have had a lot of recommendations actually based on the lessons learned. I would say we could, some of the recommendations are that a compilation of common errors on the application, for example, why we get it and how are we going to deal with it, and also to have a dummy facility to test the real data collection process, and also to use of spare user accounts, introduction of an iOS application or web application to support the Apple devices to be used in data collection, and also add extra features on HHFA application to control which facilities can be assigned for data collection and by which user, and also to allow to retake time for facility start and facility end, which we found that we had to restart the whole application whenever we had to stop it, because even if we click accidentally, there's no option to take the correct timestamp in it. So these were some of the recommendations that we compiled based on the lessons learned. Thank you so much.
Thank you very much, Mrs. Taslima. Thank you. Now over to our colleagues in Somalia, Mr. Hassan, and then Mr. Kamlachu. Over to you. Thank you.
Okay, thank you. Hope you can see my screen.
Yes.
Thank you. Thank you so much, and good morning, good afternoon to all panelists and the other participants. Somalia is also one of the countries who conducted Harmonized Health Facility Assessment, and I want to give you a brief information, the process, as well as during the data collection, and also the challenges, the lessons learned. My presentation outline will be description of Somalia Harmonized Health Facility Assessment, experience of the preparation, including the training and the team preparation, experience of using the updated CESPRO tools and Harmonized Health Facility materials, the data collection analysis and information use of the product, and tips for countries when planning and implementing a Harmonized Health Facility Assessment. And Somalia also implemented and also used a comprehensive and standardized health facility, the census. We surveyed all health facilities, both public and private, and we adapted the tool as a census, not partially surveyed some of the facilities like some countries did. And the purpose of Harmonized Health Facility Assessment for Somalia is to fill critical data gap in health service availability and readiness of health facilities, to offer care understanding and quality of care, including adherence to standards and patient outcome, and also to provide available information on management system in health facilities, including financing, provide information on functionality of health system to support UHC implementation in the country. There are some projects coming, new funding from World Bank as well as Global Fund that will be targeting to the operationalization some of health facilities that closed due to the gap in 2022. So it is very important that the Somalia should undertake the Harmonized Health Facility Assessment to at least know the service availability at health facility and as well as the readiness of health facilities to fill the gap. And why Somalia conducted the Harmonized Health Facility Assessment? Somalia is making a big efforts in the health sector for the last 5 years. We revised our essential package of health services, the health service framework, EPHS 2020. And we also made institutional reform. We established intergovernmental dialogue that the Federal Minister of Health and State government is discussed the strategic plans and operationalization external support, such as Damal Afmat project supported by World Bank through the government country system mechanism, Better Lives as a project that's supported by the UK government, and the new funding cycle from the Gavi under the Global Fund. And this is the Harmonized Health Facility Assessment is very important for these reforms that Somalia is making. And Somalia has decided to undertake this important and demanding exercise with the partners. To meet this, the ambition is the health facility assessment needed to be comprehensive, encompassing all fields of health service delivery and the assets needed for the health facility. It has to be inclusive across all service providers, both public and private, and we assessed except the private with OPD clinic, but all the private with inpatient clinic and all public health facilities we assessed during the collection. We also needed to have the data high quality from the data collection to storage, analysis, and use, and also transparent and participatory process. That we invited all partners during the pre-workshop and also the orientation of all partners involved in the Somali health sector. Building durable capacities for data management and informed decision making. It was also an advantage for the health management information team to practice, to learn the process and also the data collection, the supervision, and also providing immediate feedback to the field team. Able to inform a research agent, it was really a true public good for health. And why should Somalia conduct the HFA? Access to quality health services is central to achieving universal health coverage. And we also need reliable data information for the health facility services, as we are expecting to kick off new projects. It is very important that we know where we have less intervention and where we have more intervention in terms of health facilities across the country. To make health service improved and strengthening the service resilience, countries need reliable baseline information, and that's why we should conduct the Harmonized Health Facility Assessment. And we also used and assessed, we measured the service availability, the capacity to deliver the quality of services using by the modules, the standard questionnaire. And we identified the strength and weakness of health facilities. Each health facility is assessed, highlights highlighted inequities in health facility services, monitor changes in service over time, and provide reliable data to health system partners. And this is the execution process, the flow chart. We started up to the end, and now we are at the final stage for preparing the report, and also to call for a workshop to disseminate the result and launch to the outcome. But here is the follow chart. You can see we started with the prepared health facility list, verified from different sources, including demographic health survey, surveillance, private health facilities, and other surveys conducted by various partners to determine how many health facilities we have across the country. Even we have a strong district health management information system that all public health facilities report regularly in each month and weekly for the surveillance data. Determine required budget, number of supervisors, and data collectors for each district. Review the generic comprehensive health facility assessment survey questionnaire and amend in some areas, customizing to the country. We organized number of meetings and review questionnaire and testing the tool for the actual work to the field. Resource mobilization, we also conduct a resource mobilization meetings, then conducted TOT for the team, the cascade training, data collection. We also did the third-party monitoring for data verification in order to make sure that the data is relevant and also inform the policy and planning. We also undertake the data cleaning. Really, it was also a process that we took, and we used the supervisors, the health management information officers at the district, the regional level, to clean the data, to go back to the field and ask further questions if where we got outliers for the data. The data analysis, report preparation, what we are currently doing, and finally we are expecting to prepare a workshop to disseminate result and launch to the outcome. We also did a preparatory workshop before the actual workshop to familiarize the partners, the NGOs, the technical agencies with the objectives and the need of conducting the Harmonized Health Facility Assessment in Somalia. The scope of the assessment as a comprehensive, inclusive, and disaggregated, established data quality assurance mechanism for information collected from the health facility in a real time. Deciding on data collection, which tool to use, and also the means, the storage. We also decided analysis and immediate and long-term use for the data. Divide the roles and responsibilities. The technical, we established a technical working group and partners, governance, estimating resource needs, time, workforce, and funding. The methodology, maybe I will give now to Kumla to take it from here up to the Kumla. Welcome, brother, to continue from here.
Thank you, Hassan. Let me share also my screen. Would you allow me to share my screen?
Okay, let me close mine. I hope you can share now.
Okay. Thank you very much, Hassan. So on the methodology, it's a cross-sectional survey. We have used the electronic device to collect data. It's as Hassan has said, the census. We have included all public health facilities from bigger referral hospitals up to the public health units. And it took a long time. We'll show you why the reason it took more than a year. But on average, the data collection was taking like 15 days for each health facility. That's actual data collection. But when we include the TOT as well as the cascade training, it will take the whole month intensively, non-stop. 30 days are required. So during the preparation, one important step we have done is piloting the tools. Of course, we have tested the tools before going to the actual data collection. We have selected few health facilities from different types, big hospitals, MSED, private hospitals, clinics, and also public health units. We send them team data collectors and supervisors. And we did almost actual data collection, which helps us to estimate the required time to complete the survey in one health facility. And also it helps us to determine the number of data collectors and team monitors. And we using that very important information, we proceed to amend our plan and also amend the required number of enumerators and supervisors. In total, we have used around 830 data collectors throughout the country, and also around 262 supervisors. Somalia also used third-party monitors parallelly to validate and also for quality check purpose. During the data collection, we were doing a daily review meeting where every evening at 6 p.m. we come together, we review the whole progress, how many health facilities planned and how many completed, how the completeness looks like, because in every health facility in a team, there's a team doing different sections, and we need to check if all sections are completed, checking the server, checking the raw data. If there is incomplete information, we make sure that health facility is completed before we're proceeding to the next health facility. We also use that of the third-party data during the data collection process to complete if there is any missed one or any wrong information is collected. And also we use the third party after the survey. Data cleaning for completeness of information and also verifying all sections. If all sections were completed, we were checking for doing data cleaning. If there is missed information, even after data cleaning, by the way, during the actual data collection, we have seen, because it is very vast, we have seen some incomplete information, and even we contacted the health facilities again to get accurate information. Also, incorrect informations were recorded, like some geolocations were validating whether that is accurate or not. And we also get additional information. Some outliers of information also identified and corrected. In some areas, we are not able to complete the survey because of various reasons. Some of them, there was a huge flooding, so we need to wait and complete that information. In some areas, the health facilities were closed. We heard that some partners are no longer supporting that health facility. It is closed, so we're not able to collect information from those areas. So we exclude these health facilities from the analysis. Also, some health facilities from the inaccessible areas were excluded, but there are very few. We use the data also for data analysis, thanks to the excellent resource developed by the HQ team. They have also really very user-friendly and helpful data analysis platform. We use that one. Also, it helps us to quickly see our indicators. We used indicator inventory standard from the analysis platform. We calculated the indicators and we generated indicators disaggregated by geographical area, type of health facility, and also the management authorities as well. These are the main categories. In the data collection, it was phase-based in Somalia. Maybe it is a little bit unique, mainly because we are not able to get enough resource to cover the entire country at the same time. So in August, so almost a year ago, Puntland was the first to cover, followed by Banadir, which is the capital, Mogadishu, and then we went to Southwest and Jubaland. Hirshabelle was the fifth one, and the last one was Galmudug. Mainly, it was a lack of resource, so we were looking for the resource from different programs. So whenever we get some money, we just implement some states. Funding mainly it was from WHO, from the programs. Also UNICEF supported us in Puntland. How the result is going to be used, HHFA survey data provide evidence to guide the UHC scale. It is already indicated, the national baseline information. It is some of the information we have generated is very new. We never had that information. So it's going to be a baseline. It helps partners by informing critical investment into the health facilities to improve the delivery of the UHC benefit package, and also the essential package of health services. It has created foundation for more regular and standard service can be available. During the data collection, we were promising the health facilities that they will be the primary users of their data, and we'll show you, we ensure that they will have access to their data. And this is a number of tables summarizing the number of health facilities by state and by type of health facilities. In total, 1,219 health facilities were surveyed, different types of health facilities. Majority are health centers, public and private health units. There are district and regional specialized hospitals, and private hospital, private facilities, specialty hospitals, mainly private, are also included. In the data dissemination, we have developed the national and state level report. It's almost completed. We will have also a detailed annex of report for all major indicators by region, by type of health facility, and by management authority. We'll have an interactive web portal which will access all the levels of at all levels, which can be accessible by at all level, including the health facilities, and it is very interactive, and they can generate the data. Of course, raw data is also another data set we'll share with anyone who can do their own analysis. This is an example of how the survey result looks like. Distribution of health facility by type and state. But this is distribution of surveyed health facilities by management authority and state. And also the second table bar chart is by authority and facility types. As I've indicated, we are working on developing a web portal which has capacity to generate information supported by GIS. It also gives some spatial information as well. It generates population accessible, having access to specific health services within 40 kilometers, within 20 kilometers, within 10 kilometers, even within 5 kilometers. So when you look at that, you will be really find for example, this one is percentage of facilities offering pediatric, preventable, and curative services within 40 kilometers. As you can see, the proportion of population living in the 40 kilometer is around 16%. We have this information for all variables, for all indicators, and I will show you later when I finish. Some of the challenges we have faced is insufficient financial resource, as I already indicated. We're doing it phase by phase, and it makes the survey very expensive. We have also, as you know, we have some challenge because we don't have reliable population data while generating the indicators. That was one of the challenge because the population is a little bit dynamic because of so many issues here. Limitation to conduct the survey supervision and the data validation activities, especially in the insecure areas. Not able to generate final country level indicators because we are still trying to conduct some part of Somalia, like the north part. Without that, it is not possible to generate country level indicator. The size of the assessment made the cost of the survey to be relatively high. The modules also contain large number of variables and made the survey tool require long time. It's taking the whole team the whole day. It is a little bit long. Lengthy questionnaire and time to administer the questionnaire considered too long by the interviewers. Insecurity in most of southern central Somalia, especially. This security issue is in southern central Somalia. We are not able to conduct a survey in some health facilities. Some of the lessons we learn is that adaptation of the new HHFA tools is critical. It's very helpful. It's a wonderful tool to enhance the user. It's user-friendly tool, and it will ease data collection and also helps us to harvest required data and to produce meaningful information in the health system. The other lesson is it is important to pilot before full implementation will give opportunity for better preparation. We need to make sure allocate sufficient resources. The team selection is critical. What we learned is that it is very technical. The questionnaires are very technical, so we need to make sure that we are recruiting professionals who knows the public health system very well, and some people who have some exposure in some specific areas. As I have said, it takes at least 30 days full dedicated team, including 10 days TOT, 10 days cascade training, and also the data collection. Delay in rollout or assessment increase the overall cost of the implementation in different aspects. And also it is very critical and effective planning and implementation required all HHFA technical person in one place to avoid any of the delays. The other is close technical guidance from HQ, regional office, and partners is crucial in the successful application of the assessment. They have really a good resource. So having the HQ regional office team involved or supporting is very important. Utilizing existing gadgets for Somalia, we didn't buy any mobile or any tablets for this survey. The surveyors themselves, the data collectors, they come with their own Android phone. So it is possible also. Improve the planning activity, taking into account availability of resource, human resource, time, and financial and material. Allocate good time for TOT as well as cascade training. There is no need to rush. We need to, because that is the most important activity in this survey. The TOT and the cascade training, the data collectors, they need to understand each and every question before going to the field. Reduce the length of the questionnaire, remove some repetitions. We have seen some repetition duplications in different sections, the same question again. So that I know HQ are receiving feedback from countries, and that is very good to review again and avoid the duplicates. Assign data collector, team lead, and supervisor role in the CISPRO tool This is one of also our recommendation, or what we learn before the team is going to the field. The CISPLO, the role should be assigned, and they should not switch to change or the role during the data collection. It will affect or even you may lose data. Having the clean master health facilities is essential at all stages. Of course, before the survey, that is very important. We need to have the master list. It will help for planning, budgeting, and especially while configuring the CISPRO tool, we need to have this master facility list before we are heading to this survey. Functionality of the CISPRO tool should be checked, and IT team should be standby. Thanks to the IT team, they were standby and supporting. So this is one area we need to consider. Engage third-party monitoring will also help to get more quality data. Before I close, if I can share the portal. I don't know if you can see my screen. If you can see my screen, this is the portal we are working. So as we have promised to the health facilities, they can select their health facility name. They can select indicators from here. Okay, all indicators in the list are already here, and they can generate whether that specific health facility is providing that specific service or not. So we can add more indicators, and this will help not only the health facility, but also the partners can easily check and the service, and they can support that health facility. As I have shown also in the presentation, we can generate the indicators by health facility type, by geographical area, by state, and also by management authority for each indicators. So it will make it more interactive, and anyone will easily use based on their need. Here also, service availability for different services. They can select any indicators, for example, immunization. So they can select the distance from the health facility, and they can generate the proportion of or the population proportion where they are living within that radius, within 10 kilometers, for example, for API. Somalia, as you can see, the average are 23% of the population are living within this area. This is a new finding, by the way. So without fixing this, we cannot. So this is very helpful. We'll continue working on that, and thank you very much. Over.
Thank you very much, Kamachi. Thank you very much, Dr. Hassan. Now, quickly over to Dr. Amani Siam, representing the Regional Office for Southeast Asia, and then to Dr. Benson, representing the WHO Regional Office for Africa. Dr. Amani, over to you. Thank you.
Yes, thank you so much. And Caroline, and it's really a pleasure for me to be part of this panel and to hear the three country experiences. It's absolutely fascinating to see how each country handled the harmonized HFA. And I just have like three key messages that I would like to share with you. From a regional perspective, we are facing in the Southeast Asia region, it's a region of 11 countries that have about a quarter of the world's population. The challenges we face are increasingly a heavy burden of NCDs that are more or less responsible for about 70% of the burden of mortality. And one of the key things we see is that, do we know or not whether our services are ready to treat patients, to follow them up, to understand their needs, to have a bit of connectivity at the community level or at nearest household level? So all countries in Southeast Asia region, with the exception currently of Maldives, really have not conducted any sort of facility survey in the last 5 years. So what we see is the experience from Maldives is a big step forward, whereby we think some of the key findings that will emerge, just like you now saw from the fantastic portal of Somaliland, that we can actually put such real-time data to understand the state and status of service delivery. So I cannot emphasize the importance of that, especially as most of these countries are really keen to reorient their health systems towards PHC as the means and ways to ensuring universal health coverage. So that, I would say, is our first priority. And our second priority that we really can really see countries probably are going to be interested in trying this is the fact that the harmonized HFA is a journey. It's a way and means by which we are really checking on service delivery given the latest available service standards. So when you say essential packages of care, what does that mean in country context? When we say essential diagnostics, essential equipment, essential guidelines, it's a way and mean by which countries actually can sit in a place where they can review all of these latest evidence and sit and observe where are the gaps, where are the service delivery points not really able to provide. Is it a shortage of certain equipments? Are they using the right guidelines? Do they have the qualified staff? So as simple and as complex as it seems, it's really a way forward by which we change the mindset that we are looking to see whether at least whether we have what's enough, what's adequate to provide services. So that for me is an essential point to convey. And third but not least, of course, is the idea of the digital transformation. I need to lean a little bit on this to tell you what is happening, because the times when we were doing the service availability and readiness, for instance, the SARA or any sort of facility-based assessment tools are changing in the sense that there's a more of a need to actually record and register. And that's what I like from what Maldives experienced from Slima when she said, we created a baseline. Ghana, we've created a baseline. Somaliland, we've created a baseline. The whole concept is that with these sort of snapshots with the harmonized HFA, we can even monitor whether progress has happened or not. Where are the shortfalls? Which localities are hard to reach? Where are the issues? What sort of commodities are missing? Is it a combination? Is it a multitude? So in its simplistic way, you see it by those bar charts, the percentage of facilities that have access to oxygen in OPD. How many are they? Can we generate these comparable indicators for countries and within states, within countries? So the sky's the limit. The kind of data that comes in with the HFA, it really unlocks multiple sort of comparisons to be made, and with it, evidence-based interventions to follow. So I just wanted to transmit these messages. And again, thank you for the 3 country presentations. Quite impressive and quite informative, even to someone like me, who I do think I know the harmonized HFA, but we do learn every time we see a country presentation. Thank you, and back to you, Mr. Chair.
Wonderful. Thank you very much, Dr. Amani. Benson? Dr. Benson, over to you.
Yeah, thank you so much, colleagues. I hope you can hear me.
Yes, we hear you loud and clear.
Yeah, thank you so much. And I'm so sorry I can't put on my video. My laptop is on a docking station, so it is very difficult for me to share my video at the moment. I want to thank the organizers for inviting me to share my experience with the Harmonized Health Facility Assessment. And I also want to thank the countries that have made the presentations to share the experiences and also what they expect of the Harmonized Health Facility Assessments going forward. I've been involved with the HHFA work for quite a long time now, starting with the previous version, which is the Service Availability and Readiness Assessment. I worked at the headquarters in Geneva, and at the time with Amani and others, and we helped to coordinate this work across the world, with so many countries at the time implementing the Service Availability and Readiness Assessment. And that tool actually gave birth to the Harmonized Health Facility Assessment. The basis was that so many partners at the time were doing similar work, and therefore it was important for the partners to come together, come up with one common tool that they go to countries and support countries to implement. So that's really the basis for the Harmonized Health Facility Assessment. It's not entirely new tool, given that a lot of the questions in the then SARA assessment tool have actually been retained. And I really want to thank Wendy, Steve, and Craig for the leadership they have shown in keeping the tool and improving on it, and also making sure that countries are supported to implement the Harmonized Health Facility Assessment. Now, in the African region, quite a number of countries have really implemented. First of all, they've embraced the Harmonized Health Facility Assessment. And we have several requests from countries for support to implement this survey. About 8 countries have completed assessment, and this includes Kenya, Burkina Faso, Liberia, Zambia, Uganda. Anthony also just talked about the assessment in Ghana, then Democratic Republic of Congo and Burundi. And as we speak now, there are ongoing assessments in 4 other countries: Rwanda, Cote d'Ivoire, Guinea-Bissau, Zimbabwe. And also going forward, there are, I think, 3 or 4 countries that have planned to implement the assessment. Kenya plans to do the second round. South Africa is hopefully in the pipeline. We started engagement with them. Somehow it has gone silent, and I hope it will pick up after the after December. And also Sierra Leone has reached out to us. And I'm sure there are so many other countries that are going to come up in the year 2024 for support to implement the Harmonized Health Facility Assessment. They are doing this because they know the value of this assessment. This Harmonized Health Facility Assessment provides very useful information on service availability and readiness. I can share with you an experience during the COVID-19. When the COVID-19 hit, there were, I think, only 2 countries that had implemented the HHFA. And of course, many that had implemented the service availability and readiness assessment. Countries that had this data when the COVID hit, they were able to quickly adjust their systems, because when the COVID hit, people needed to know what capacity do the facilities really have to implement COVID response. And countries that didn't have this data struggled. They were trying to collect data at the time of a crisis, which was incredibly difficult. So countries like Kenya, they were able to move quickly, put in place some systems to address the COVID challenges. So that is how useful this assessment really is. And I can talk the whole day about why it is important for countries to implement the Harmonized Health Facility Assessment. We have tried to actually set the agenda for HHFA in the African region. We have organized regional meetings where we invite everybody virtually to talk about the Harmonized Health Facility Assessment and why it is important for them to implement. That's why we are seeing a lot of requests coming from the countries to have this assessment. The abortion model that has been included quite recently, actually some partners have found it very, very useful. Just a case in the question is the interest from the Buffett Foundation, because they are now interested particularly in funding that component of the HHFA, looking at how can we improve the care, the abortion and the post-abortion care in the countries, particularly in developing countries where access to these services is extremely limited. People don't even know whether the facilities have the capacity to provide appropriate abortion and post-abortion care. HHFA tool is coming in to help in that. It is really helping a lot in that. Now, with all the nice things I've said about HHFA, also there are particular challenges with HHFA. I think all the speakers that have come before me have mentioned this already. One of them is the issue of funding. It is fairly expensive, as you know, to implement the Harmonized Health Facility Assessment. On average, when we were implementing SARA, we estimated that if you have to visit one facility, on average, you need about $1,000. Now, the HHFA is a very big tool, and probably you need more, but also the experience from Zambia tells us that actually it is possible to do it at a cheaper price than the expected value of $1,000 per facility. Zambia visited over 3,000 facilities. They spent less than $700. They collected all the data, produced all the report in a record time. Of course, we put our boots on the ground as well, supported them to generate the data. In some countries, they have done 700 facilities for $1 million. So you can see how expensive it is, and also how time consuming it is. So HHFA is both labor intensive, and also cost intensive. So at the regional office, we are beginning to think, should we perhaps take a few steps back and start thinking about exploring some modalities of collecting this data? I'm happy Anthony of us also talked about this as well. We are thinking about, can this data be meaningfully collected through the routine health information system? And how will it look like if we are to collect the data through the routine health information system? We're not saying that the entire tools will go and be reported through routine information system, but can we start with a few of the questions, see how it works? If it doesn't work, we leave it. If it works, then we improve on it and see if we can report on, collect HHFA data through the routine health information system. It may be DHIS2, it may be another system, maybe Excel sheet, or the current approach that we are using, like using the Dropbox. The data are collected and they sit somewhere in the Dropbox. The same analysis method will be used, the same data analysis platform will be retained, the whole questionnaire structure will be retained, nothing changes, but what will change is just the approach for collecting that data. That is what we are looking at. And we really are interested in this. We'll be happy if HQ, you can really also agree with some of these approaches and we try to explore. I'm not saying it works. I'm not saying it works, but I'm saying, can we try to see whether it works? Can we explore it? Maybe either in implementation, research, or whatever we want to call it. Can we try to explore to see if it is possible, if it is feasible? If it is not, then we abandon it. So the second thing is, really we need to mobilize, we need to engage as much as possible to make sure funds are available for the Harmonized Health Facility Assessment. I sometimes when I look at how Wendy has struggled with also, of course, with Steve and Craig to try to look for money for the Harmonized Health Facility Assessment. Even here at the regional office, all the weight that for looking for money comes onto me because I'm the first contact for the countries when it comes to HHFA. We have tried all the countries that have reached out to us. We have managed to get some money for them. We have reached out to partners, even within the regional office. What we do is we quickly prepare a brief for all the programs, showing them, look, this is really how important the Harmonized Health Facility Assessment is for you. And we have actually a brief that shows how many HIV indicators are there, so that when we're asking the HIV program to give us some money, you see, look, with Harmonized Health Facility Assessment, we're able to generate data for X number of your indicators. We go to NCD program. For NCD program, if you give us some money, this is how much we can help you generate the data for you to monitor your NCD program. You have this number of indicators. We have that. We have, and HHFA actually has this indicator also disaggregated by program. I think we need to make use of more of that to put the agenda before programs so that they're able to fund this data. Because programs are using this data. When it comes to using the data to monitor their own programs and implement their own programs, they use it. But when it comes to saying, oh, we need money to implement HHFA, not many programs are happy to fund this. I really want to, at the regional office in Africa, I want to thank the reproductive maternal child health team. They have been our angels, really, when it comes to funding. They have helped a lot to give us money to fund because of the abortion care model. We're not saying we should expand the tool enormously because not every program should be adding so many, because we want to keep the tool also at a certain standard. A huge tool affects the quality of the data. It means you need to spend more money and more time in the field. So let me stop here. I could talk on and on, but I think just to once again say, one, it's a very important tool. Two, we should find new ways of collecting the HHFA data that may be through the routine health information system. Please, I'm not talking about DHIS2 only. I'm talking about exploring the use of the routine health information system with or without DHIS2 in this case. And I'm really looking forward to such an approach. And of course, thirdly, engaging more people. We really need more money to support the countries to implement the Harmonized Health Facility Assessment. Sorry for taking longer than I had planned. Thank you so much. Over.
Thank you very much, Benson. Thank you all to Taslima Kumlachu, Dr. Hassan, Dr. Anthony, Dr. Amani, and yourself, Dr. Benson, for the wonderful presentations. It was really rich and great to hear from all the countries. Unfortunately, we're over time, so I will hand over quickly to Craig for some closing remarks. Thank you so much. Over to you, Craig.
Thank you. And first of all, just wanted to say thank you on behalf of the Health Data Collaborative partners, and there are many of you on the call today, for taking part and listening and being part of the Health Data Collaborative together. The ultimate aim is to bring partners together and focus on how we can best support countries' needs for data. And this Harmonized Health Facility Assessment tool is one brilliant example of how we're all doing that. It's led by the technical team, Wendy, my colleague in WHO, but involves many of you throughout many of the different 6 regions of WHO. So today I wanted to thank our colleagues from Ghana, Maldives and Somalia, and I'm not going to repeat what other colleagues have said, but a huge thank you to them, and I hope it's demonstrated really how this tool can be used to inform policy, programs and budgets, as well as plugging gaps to give countries better information on which to base their decisions. Also wanted to acknowledge our country teams. When I say country teams, I'm meaning ministries of health, national statistics offices, and other teams for other partners as well, such as WHO, but also UNICEF, UNFPA and others who've been engaged with this process in many different countries. And also our regional colleagues, you heard from Amani and Benson from Sierra and Afro specifically, but our regional offices play a key role in coordinating support and mobilizing resources for countries as well. And we hope to work across the 3 levels of WHO to help mobilize more resources for countries to use this tool as much as possible. The last thing I want to say is really to advertise the HDC platform, this webinar platform, to anybody who would like to share good practices, share good tools that you may be working on, get feedback on those, and just share within the collaborative community that is so rich with our data and digital colleagues from multiple different agencies. And if you do have anything to share, Carolina and the Secretariat colleagues are organizing events for next year, 2024. Please email healthdatacollaborative@who.int, which is the Secretariat's address, and we really welcome a schedule that we're putting together for next year as well. So thanks to everyone who's joined. For those of you who don't know and hasn't got the invitation, the Health Data Collaborative will be meeting in person and as a hybrid event in Nairobi on the 5th and 6th of December. Everybody is welcome to contribute to that event, where we're inviting 13 countries to share their good practices and look at the ways in which the HDC can move forward. So thanks again to our colleagues in Ghana, Maldives and Somalia, a very rich discussion, and thanks to everyone for joining and for Carolina for helping to moderate. Thanks everybody, and have a good rest of your week. Thank you.
Thank you very much.
Thank you all. Bye-bye.
Thank you.
Thank you.
Bye.
Thank you.
Bye.
Thank you very much.